Yeah. So Ashish, you can begin.
Can everybody see my slides?
Yeah, we can see your slide.
Hello, I'm Dr. Ashish from HIEM third batch, and this is my first teaching here in the group. I chose this topic as it's very common in the ED and at times very challenging to approach anxiety disorders and panic disorders. So today I'll be covering the general definitions of anxiety disorders, the epidemiological and different types as per DSM-5 of anxiety disorders. I'll go into a bit detail about panic disorders and generalized anxiety disorders. So how are anxiety disorders different from our normal anxiety or fear of day-to-day life? Fear and anxiety towards your left, you can see fear is the emotional response to real or perceived imminent threat, whereas anxiety is the emotional response to anticipated or future threat. Is my voice clear?
Yeah.
It is usually induced by stress, whereas anxiety disorders, on the other hand, they are excessive fear or anxiety, and they usually are related with behavioral disturbances, and they are usually out of proportion to fear for objects and situations, which normally is we don't have that much fear or anxiety towards. And usually anxiety disorders persist for usually a period of 6 months or more. Coming to the epidemiology, usually anxiety disorders start in childhood and persist to adulthood. And with female predisposition, which is more 2:1 ratio of more in females than in males. This table is from Oxford Handbook of Psychiatry. It gives the estimated 12 months prevalence of anxiety disorders in the general population of the European Union. As you can see in the table, for anxiety disorders, about 14% of the general population are estimated to have anxiety disorders in a year, which is about 61.5 billion people, which is a lot, and so on for different anxiety disorders thereafter. So I'll be going one by one for the different types of anxiety disorders according to DSM-5. First one being separation anxiety disorder, in which the person is fearful or anxious about separation from attachment figures to a degree that is developmentally inappropriate. Second, being selective mutism, as shown beautifully in this picture. It is characterized by consistent failure to speak in social situations in which there is an expectation to speak, like in schools, and but the child or the person is can talk normally in other situations other than that. Third is social anxiety disorders or social phobias. In this, the person is fearful or anxious about or avoidant of social interactions and situations that involve the possibility of being scrutinized. These circumstances usually are like meeting unfamiliar people, situations where people may be observed eating or drinking, or situations in which person performs in front of others. All these may be included in social phobias. Next is specific phobias. In this, this includes, this is very common and we all have seen this, in which there is out of proportion fear or anxiety to specific objects or situations, like as shown in this picture, like thunder, or fear of flights, or needles, or spiders. And the treatment of choice still remains behavior therapy. And there are different behavior therapies. To be specific, there are 3 different types of behavior therapies, which are very interesting. So I'd like to tell them. First one being graded exposure, in which people are gradually exposed to the specific stimulus that they are fearful of. And second one being systemic desensitization. This is the best and the treatment of choice for behavior therapy, in which people are they do deep relaxations like meditation, and they imagine the fearful stimulus, like imagining airplanes or needles, if they are fearful of that. Third one is very interesting, which is called flooding, in which if you are afraid of dogs, for example, you will be kept in a room full of 10 dogs. That is what flooding or supramaximal exposure is. Next is agrophobias. There are 5 different types of agrophobias according to DSM-5, and first one being fearful or anxiety about public transportations. Second is anxiety or fear towards open spaces like parking, marketplaces. Third one is fearful or anxiety of enclosed spaces like lifts, theaters. Fourth is standing in lines or being in crowd. And fifth one being outside home and alone, that causes anxiety or fears. Other than that, DSM-5 includes panic disorders and generalized anxiety disorders under anxiety disorders. They have excluded OCDs and stress disorders from this classification in the 5th edition, which was there in the 4th edition. So that's the difference here. They have made a different section for OCDs altogether. So coming to panic disorders, does anyone know what the figure or this picture is of, or what is this? Anyone good in history? Sort of like, do you know what this is?
No idea. It's more of a mythology thing, I think.
So this is the Greek god Pan, from where the word panic comes from. So this god was is thought to be a Greek god. It is a Greek god, and the god was used to frighten humans and animals out of the blue. So that's how the panic disorders came to be called panic. So we all have panicked in particular situations, but how is that different from panic attacks or disorders? So panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes and lasts usually for 20 to 30 minutes. They can last more than that as well, for hours at times as well, but it's rare. And DSM-5 gives different symptoms, 13 to be specific, out of which 4 or more needs to be present. I'll tell them a little bit later. And panic disorders. They are recurring unforeseen panic attacks followed by at least 1 month of persistent worry about having another panic attack or concern about consequences of a panic attack. And panic disorders are usually there without any substance abuse or any medical conditions or other mental disorders have been excluded, then we can say it is a panic disorder. So coming to the etiology of panic disorders, different bases are given, like biological basis, in which serotonin and GABA receptors are low, have been postulated, and high noradrenaline levels have also been postulated to be a cause of panic disorders. Other than that, genetic predisposition to panic disorders have been seen, but specific genetic markers have not yet been identified. So that brings us to a case of a 32 years old female. Let's call her Mrs. Y. So this is Mrs. Y, who came to the ED with history of palpitations for 1 week. And she has been going through all the news of COVID and all that. So she's very anxious and she's waiting in the waiting room. She has a history of fever and respiratory symptoms 3 weeks ago, which has resolved. But since then, she has been increasingly feeling tired and feels her heart racing when she's lying in bed at night. And she has noticed reduced exercise tolerance. So I see the nursing staff talking in a corner saying, looks like there we have another panic attack in our hand, and a nursing staff is going to take the ECG. We'll get back to the ECG as she comes back with it. Let's discuss the signs and symptoms of panic disorders till we see the ECG. So, as I told earlier, there are 13 different signs and symptoms that the DSM-5 gives, out of which 4 or more needs to be present to be called a panic attack. 9 of them are shown in this picture, like in our history. Palpitation is one of the symptoms. Other is hot flashes or chills, fear of death or fear of impending doom, shortness of breath, numbness or tingling, or shaking or trembling of limbs are also a symptom. Upset stomach or nausea is another symptom. Sweating, dizziness, chest pain or discomfort, these are symptoms. Along with that, feeling of choking, feeling of losing control or going crazy, and derealization and depersonalization are also different symptoms. So the nursing staff comes back with the ECG, and you are asked to review her ECG to determine whether she can be streamed to the co-located GP. Can anyone tell me what are 2 abnormalities that you see in the ECG? Anyone?
Yes, short interval, and I can see delta wave. This looks like a WPW.
Anyone else? Any other interpretation?
Peaked P waves anti-inversion in B5, B6, B4, and also lead 3. Lead 2, sorry.
So there is widespread T wave inversions in septal, lateral, and inferior leads, V3 to V6, 1 to 3, and AVF. And there is a QT prolongation also. Other than that, P wave in
Hyperventilation induced.
Could be. We'll go through this case as we go on to the presentation. These are the 2 things mainly that I was looking for. So keeping that in mind, let's move forward. So after looking at the ECG, so you decide to go and to see the case, and you call her in from the waiting room to assess her yourself. She appears short of breath on walking 50 meters, and she has no past medical history as such, and she's not taking any medications as such. She smokes and says that occasionally she takes alcohol. She exercises regularly and was able to run about 5 miles until becoming ill 3 weeks back. And she has not had any chest pain or leg swellings. She has no risk factors for ischemic heart disease or venous thromboembolisms. On a brief examination, her chest is clear and there's no ankle edema. Her heart rate is 110 beats per minute, and on hearing her chest auscultations, you think that there is a gallop rhythm present. So keeping all this in mind and the history given in before, what are the 2 investigations that you'd like to request most urgently in the ED? Any 2 that you would like to do? Anyone?
Troponin and chest X-ray.
Yeah, chest X-ray would be good to see if there's any cardiomegaly, heart failures, pulmonary edema, or any lung diseases as such. Given the ECG prolonged QT intervals.
Quick VVG to check the calcium levels, pH as well, and carbon dioxide levels. I know it's not ideal for the carbon dioxide to be visible in VVG itself, but at least that would give us an idea. And
that would be good. So I would like to see, since the ECG had some QT prolongation, so some electrolytes of potassium, calcium levels would be good. troponins maybe level or serum troponin level may be good to see if there is any secondary myocarditis. And D-dimers, as she's short of breath, the history of 1 week is there. Pulmonary embolism can be ruled out. And if we can do a echo, bedside echo in the ED, we could do that. So keeping all that in mind, till the investigations come, let's finish up the theory part of panic disorders and generalized anxiety disorders. So panic disorders, as I have already said, investigations, no specific tests need to be done for panic disorders as such. You diagnose it with the DSM criteria if it's present or not. But the person is coming, as we saw the Mrs. Y, we can exclude the physical causes or medical causes like some cardiovascular or respiratory causes, some endocrine causes like hyperthyroidism may cause anxiety disorders or panic disorders, hypoglycemia, hypoparathyroidism, and they can be ruled out if the history is indicated as such. So emergency treatment for an acute panic attack. First of all, we'll reassure the patient and we'll try to calm the patient with a calm attitude because most panic attack, as I said, resolves spontaneously in 30 minutes. So that would be really helpful. Other than that, if the symptoms are very severe and distressing, benzodiazepines can be given according to that's what we have been practicing, and that's what Oxford Handbook of Psychiatry says. But NICE guideline strongly disagrees with that, and they don't recommend giving benzodiazepines in patients as per the NICE guidelines. But Oxford Handbook of Psychiatry says that clonazepam, alprazolam, or lorazepams can be given if there is acute panic attacks. And as I have mentioned earlier, and some will be needing admissions if they panic disorders are treated in a stepwise manner. According, this is taken from the NICE guidelines. So I'll go to the steps. There are 5 steps. First one being recognition and diagnosing the panic disorder. Second one, after we diagnose the panic disorder, if it's in the mild stage, we can go for treatment in primary care. There are different treatment options like psychological therapies, medications like SSRIs, SNRIs, or TCS, and self-help can also be given at this stage when the panic disorder is in mild. The treatment, the choice of treatment depends on assessment process as well as shared decision making with patients. Third step is for moderate to severe panic disorders. We'll review and offer alternative treatments like cognitive behavior therapy and an antidepressant like SSRIs or SNRIs or TCAs can be given. No specific drug of choice is there. All the 3 are equally effective, but we usually start with SSRI like sertraline or escitalopram. Other than that, venlafaxines or can be given, and if these don't work, then we step up to TCS like imipramine or clomipramine. Though it is not yet licensed according to the Oxford Handbook of Psychiatry, but it is practiced, it says. And if these steps don't resolve the panic disorders, we go to step 4. And if a person is already taking 2 interventions and the person still has significant symptoms, then referral to specialist mental health service should be offered, and care in specialist mental health services are given in step 5. Coming to generalized anxiety disorders, this is from DSM-5. The diagnosis diagnostic criteria includes a person having a generalized, free-floating, and persistent anxiety, along with apprehensive thoughts of worry, and 3 or more of the following symptoms for adults, like restlessness, fatigue, muscle tensions, impaired concentrations, irritability, and difficulty in sleeping. For children, only 1 out of the 6 can be taken for diagnostic purpose. So there's a question for everybody. Highest prevalence of generalized anxiety disorder is in age group of which of the 4? 10 to 17, 18 to 29, 30 to 45, or 45 to 59? Any guesses?
B.
18 to 20.
18 to 29.
B.
We all, even I also picked B in first because we have been thinking and thought to that anxiety disorders usually occur in adolescent age group, and usually 23 age group are more prevalent. That is true for all the other anxiety disorders except for generalized anxiety disorders, which has highest prevalence in 45 to 59 years, and the lowest prevalence is in 18 to 29 years of age group. And also the low prevalence is for more than 60 years of age group. So this is a etiological for generalized anxiety disorder. A triple vulnerability model has been given. This is taken from the Oxford Handbook of Psychiatry. Generalized biological vulnerabilities this includes genetic predispositions and neurobiological factors like high noradrenaline, low GABA or serotonins, and it also gives possible sustained or repeated activation of corticotropins linked to generalized anxiety disorders. Other than that, decreased peripheral benzodiazepine receptors have also been postulated. Second is generalized psychological vulnerability. This includes diminished sense of control. It includes trauma or intense attachment to primary caregivers. And the second one is parenting. Overprotective or lack of warmth from while parenting can also be a cause of generalized anxiety disorders. In specific psychological vulnerability, any stressful life events like loss of a pet or family member, or stressful events like rape can be a cause for generalized anxiety disorders. So management of generalized anxiety disorder is also given in a stepwise care model. This is from NICE guidelines. Step 1 is for all known or suspected presentations of generalized anxiety disorders. In this, first thing we'll do is identify and communicate the diagnosis of generalized anxiety disorder as early as possible and give treatment options to patients, and educate them about GAD, and treatment options are given with active monitoring. This, in many cases, will improve less severe presentations and avoid the need for further interventions in future. And step 2 gives diagnosed is for diagnosed GAD that has not improved after education and active monitoring in primary care. For these patients, low intensity psychological interventions are given. This includes individual non-facilitated self-help. In this, people are given written or electronic materials, and the person takes it home and works with that material systematically through over a period of 6 weeks. And in the second one, individual guided self-help, along with the materials that I told earlier, 6 to 7 sessions, which are weekly or fortnightly, which can be face-to-face or via telephone, usually of 20 to 30 minutes sessions are taken along with the materials. The The third one is psychoeducational groups can be advised to the patient. Third step for GAD with an inadequate response to step 2 interventions or marked functional impairment, they are given high intensity psychological interventions like cognitive behavior therapy, applied relaxations, or drug treatments. So the first line of treatment is SSRIs. We usually start with sertraline as it is cost effective to start with. And before starting with the SSRIs, a thorough history needs to be taken because it has interactions with cocaine. So a drug abuser history needs to be taken. And before prescribing SSRIs to patient with who is less than 30 years, a treatment plan needs to be made because they need to be followed up regularly. As for patients with who is less than 30 years, SSRIs can cause suicidal thoughts and tendencies. So that brings us to step 4, which is complex treatment refractory GAD and very marked functional impairments like self-neglect or high risk of self-harm is there. Then we send the patients to high specialist treatment, such as we'll add complex drugs and or psychological treatment regimens are added. Along with that, inputs from multi-agency teams, crisis services, or day hospitals or inpatient care are also advised. That brings me to the end of my presentation. So that brings, this is the case. So we have her chest X-ray is this of the patient. So what do you think is the most likely cause for this abnormality that you see in the chest X-ray? Well, first of all, what do you see in the chest X-ray?
Is it an AP view or a PA view?
PA view.
Cardiomegaly?
Cardiomegaly, yeah. Cardiomegaly can be seen. So what might be the possible cause for this cardiomegaly? Because if you remember the history properly, what might have caused this and what may be the cause? Any guesses? Any diagnosis? So the patient had given...
Pericarditis.
Myocarditis, pericarditis.
That's right. Myocarditis. Because she had given a history of fever and respiratory symptoms 3 weeks back. So maybe a viral infection which has caused myocarditis may be a likely cause. Any other possible diagnosis? Alternative to
Possible rheumatic heart disease.
Yeah, that can be there.
Rheumatic heart disease, because PR was short PR as well as carditis, as well as fever, along with the palpitations in a young patient.
There can be other causes as well, like for dilated cardiomyopathies, like for other infections like Lyme disease or other bacterial or fungal infections can also cause that. Hyperthyroidism caused dilated myocardiopathy can also be a cause. If the patient, this female, has says that the alcohol intake is minimal, but if she's taking a lot of alcohol, that may be a cause for dilated myocardiopathy as well. Other than that, some hyperthyroidism, hyperparathyroidism, or can also be causes, and cardiac diseases or atrial myxoma can also cause, maybe a cause. We can keep that in DD. So that brings me to the end of my short presentation. These are my references, DSM-5 and Oxford Handbook of Psychiatry. Nice guidelines. Everyone can go through this nice guideline. It has some thorough management regimen, and some parts were taken from Rosen's Emergency Medicine. Thank you, everyone.
Okay, thank you, Ashish, for like beautiful presentation. So basically, like Ashish, so because you haven't practiced in the UK, so if you like present, we all are emergency doctor. So if you like
Feedbacks would be because
yeah.
I haven't come there, been there
Yeah.
yet. So yeah. So I chose a topic which was very different, and I didn't
Yeah.
choose a topic that was like straightforward emergency medicine topic, because I just wanted to present and see how the feedback is. Maybe next time I'll present a better one topic.
But it's your like first presentation here, so most probably all don't know about like Ashish. Ashish works in the like Chiton Medical College, so he's willing to come here, so he will come soon. So if anybody has any question regarding this topic, we can discuss.
So Ashish, this is a very brilliant, good presentation. So even when I was presenting first time in this group, I was very shy, I was very anxious, and the same thing happened with me as well. So like I was very anxious. The main thing was, and Ulu was there to support me, and everybody was in this group is very nice. So everything is, I think you have done very good thing today. And it's a very nice presentation. Thank you, Ashish.
Any feedback from anyone? Because would be really good.
If you're asking for feedback, then I will recommend. So how many patients have seen? Like how many patients you are like in average a day? How many patients were seeing anxiety or these things? How many patients in a day? In a like 8 hours of shift, how many patients you have been seen?
Like in emergency department.
In CMC, whereas because in CMC it was very common, we were seeing a lot of panic disorders. I would say I was looking at in an 8-hour shift, on an average, I would see one patient at least per day.
So in an average, so if you come here, then I think you'll see like, if you are seeing like 10-hour shift and doing 10-hour shift and seeing 10 patients, among them you'll see like 5 patients. So I think topic is the best to choose from while you are working here. I think that's a good presentation anyway.
Based on my experience, Ashish, you will see a lot of this, but it's more of a mixed presentation. They have some problem, and they are anxious about it. One call, basically, they didn't want to come to A&E because of what has happened, but they have to come in, and they are now anxious of the environment itself. People have like a high blood pressure just out of, there's no white coat in our department at all, but still with the scrubs, they've got high blood pressure. So you will see a mixed presentation than a proper presentation which you are seeing in Chiton. So welcome soon to see all these patients and kind of implement medical diagnosis and treatment modality. Excellent presentation.
Thank you so much.
So
Thank you very much, Ashish. That was a lovely presentation. It's good to put things in context because we see a lot of anxiety-related problems here. And I so much like the case you put up there, because that case wasn't an anxiety case, actually. There was a pathology. So I think you are trying to tell us that the facts that you're telling us about anxiety today, we shouldn't always think every patient who presents that way is anxious, that there could be an underlying pathology. So I really like that spin you put into it. You know, the DSM symptoms that you showed to us, I can't remember all of them, but when I was going through your slide, the only one that I can see that will not make me make any further investigation is the one that presents with numbness of the limbs, of the hands, and of the lips. The other presentations could have a pathology underpinning them. I don't know if you still have that slide of those presentations, those DSM presentations of clinical symptoms. But all the other presentations, there could be due to MI, there could be due to PE, there could be due to pneumonia, there could be due to anything apart from the numbness of limbs. So I'm happy you put that slide to remind us that we shouldn't call everything anxiety. And here, like was it Sikandar that was telling us that you see 5 out of 10 patients with anxiety. It's true, a lot of people come in with anxiety, but we still need to be careful because, let me give you an example. Last week or so, I had a patient who was drunk, who had an RTC, but she was drunk. And I was so convinced that she had no head injury, that she's just pretending and that it's just a drunken state. Well, I just said because I have a low intensity to scan anybody who's drunk and who has had a head injury, I decided to scan her. Lo and behold, she had a bleed, intracranial bleed. So I was wrong. So if I had just, said, oh, it's nothing, I would have got into soup. So it's good. We know patients, many of our patients present with anxiety, but please, 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 I don't know if many of you have got complaints, many of you have got a coroner's report back. You will see one little thing can make a difference. So if you're in doubt, scan. If you're in doubt, do an investigation. Don't just, think there's nothing. If you have a patient who you think the headache is mild, but it's presenting with a low GCS, or you think they are drunk, or just scan. So anxiety is a common presentation, but please, like Ashish showed us now, we should still be aware of pathologies. But thank you so much, and thank you for making it very interactive. That was very good.
Olu, yeah, go ahead, Rashika, or Roshanti, go ahead.
It is, I think, diagnosis of exclusion. We shouldn't jump into it. And Ashish, it was very nice presentation. Thank you.
I just want to add one more thing, because the ATLS classification of hemorrhagic class 2 and class 3 also shows mild anxious and anxious, absolutely confused kind of anxious. So make sure any of those presentation in trauma can be relatively different, and you have to think about the worst case scenario rather than to say it might be a panic attack. Panic attack is a diagnosis of exclusion. If you can't find anything, try and ask few questions like, what's your family like? Is there any stress in the family? Is there family? What's your financial status like? And what are your, like, do you have any friends? Do you have any problems with your friends? Do you have any monetary problems at all? These are the things. And then the last bit, you just throw that kind of million-dollar questions. Have you seen anyone dying in front of you or been through an accident just in front of you? That is a classical presentation in terms of a stressor, acute stressor, which can precipitate this panic symptoms, or even when the accident happens, she just passed that, and then she start remembering, and the thought process goes on and on. The subconscious mind actually keeps all that thought together and multiplies in a significant way, and that's what pours out into absolute panic symptoms.
Yeah, I don't know if any one of you here saw a child earlier this week who presented with leg weakness, who couldn't walk with the left limb. I don't know if anybody here, that patient was seen in ED and sent to pediatrics. It's a 15-year-old who presented with lower limb weakness, and suddenly she couldn't feel in her leg, and she couldn't weight bear, and she had pain from the back to the lower limb. So this girl was sent to pediatrics, and you will be surprised the amount of investigation this girl had. ED already did CT head and CT for her. So when she got to pediatrics, she had MRI head, she had MRI spine, she had Doppler ultrasound of her abdomen, she had Doppler ultrasound of her vessels of that limb with extensive investigation. At the end, we found nothing. So she did, the specialties did every available investigation to rule out a central cause, to rule out a upper motor neuron or even a lower motor neuron cause, to rule out a vascular cause, then to rule out a muscular cause. They did CK, did blood, did everything came back negative. After all these tests have been done, the consultant on duty now came to the girl and mom and now asked, because we all knew eventually that this was more of a, atypical presentation, wasn't pathological, but everybody was wondering how would we browse it to the parent and to the girl. Eventually, the consultant went the next day and said, by the way, is there any problem? Has so been having any problems? Our mom said, oh yeah, she's changed school. There's a lot of stress at school. Oh yeah, COVID didn't help. We had a lot of stress, and they came out, start talking about stress. It was easy for him to now say, I think the problem she's having, he just told her is anxiety, is mental problems. mental health issues. And you know what the mom said? Mom said, oh, yeah. In fact, we're trying to get camps to help. It's difficult to get camps. So, and that was how it was easy for us to, tell her that it's not physical, it's mental. You know what happened? The girl got out of bed and walked out of the hospital. And for 4 days, she couldn't walk. After this discussion, just this last week, she got up, she walked out of the hospital. So it's still important to do all the tests to be sure we don't miss anything. But at the end, make sure you have all your facts before you label it as anxiety or as psychosocial.
Yeah, I think Olu, what you sounded more like the patient might have got a conversion disorder, because this is actually a presentation in conversion disorder usually.
It could, yeah, exactly. Yeah.
Yes.
I'm surprised that patient came from ED. I thought you saw the patients. I'm sure one of the ED doctors saw.
Okay, thank you, Ashish. So we will finish this session here. Thank you, everyone.
Guys, for the lovely presentation.
Okay, thank you. Bye, everyone.
Thank you. Bye. Thanks so much.
See you, Olu.
Bye, guys.
One thing.